Okay. So, yeah, let's start with, I do want to begin with a content warning. So for those of you who are here today, we will be talking about mental illness, suicide, and trauma. So if those are things that, you trigger you in some way, just be prepared that we will be bringing those things up. If you are in a crisis or need emergency help during the talk, please feel free to step away and take care of yourself. Reach out to friends or family or to a 24/7 hotline. You can find that on this website that we're providing here. And then I do want to make sure that everyone's aware that Dragonfly Mental Health is not a healthcare provider. We do not provide medical advice. This is information, this is evidence-based, and this is from the literature and the best practices, but this does not qualify, this does not substitute for speaking to a medical professional. So the talk outline today is I'll tell you a little bit about myself, a little bit about Dragonfly, including an update on our progress. And we'll touch on what this talk is meant to be and what it's not, just to set expectations. And I'll introduce the idea of the spectrum of mental health in order to just contextualize what we're going to be talking about today, which is highlighting mental illnesses. Very specifically, we'll talk about mood disorders and anxiety, burnout, psychosis, substance abuse, obsessive compulsive disorder, and ADHD. If we have time, we might also touch on the autism spectrum disorder, but we'll see. And then I'm gonna finish up after those things where we're talking about causes and treatments and contextualizing for academics. We're going to talk about the borderlands in mental health. So people who have been historically excluded from scientific and academic pursuits, and how that affects their mental health as well. And how do we make academia more inclusive? And then the rest of it we'll spend on group discussion. And so I hope that you're interested and excited at 5 p.m. German time to participate there at the end. So feel free to write questions in the chat as we go, and then we'll read through those at the end, and we'll try to get through as many as we can. Or if there's like a clarifying question or something, please feel free to unmute and ask that question during the talk. There's 27 of us today, so not a humongous group, so that should be fine. And then we'll hopefully have a nice friendly chat at the end. So my name is Dr. Wendy Ingram. I have a PhD in molecular and cell biology from UC Berkeley, and I began research as an undergrad as well. So I now have 17 years of brain and behavior research, from molecules in a biochemistry lab as an undergrad to molecular and cell biology, and now to populations by studying psychiatric epidemiology at Johns Hopkins University. And at the same time as I was conducting, my research studies and training in various molecular biology and epidemiological techniques, I got involved pretty early in advocating for mental health within academia. And I helped create peer-led organizations to address mental health problems, both at my postdoc institute, Johns Hopkins, and at my PhD institute, UC Berkeley. And then in 2019, I met the wonderful Olia, and we decided to found something bigger that could have wider impact. And that's what Dragonfly Mental Health is. And so it really, we have three branches of what we do and how we organize. The first is a global consortium for academic mental health. So we have now a cadre of 260 volunteers from all over the world. Over 30 different countries are represented, more than 45 disciplines. And our so that's a group where we conduct research and try and work to address systemic issues. within academia. We're also very dedicated to building community. And so Dragonfly Cafe is something that we launched at the beginning of the pandemic and has just, carried on in a spectacular manner, where it's a free, safe place for academics to come together and talk about, support each other and be supported in their mental health day-to-day struggles, not giving advice to one another, but to support and listen. The on-campus program is one of the biggest things that's taken off in the last year and a half. And so with that, we're trying to create culture and climate changes directly within academic communities with talks such as this. This is one of, I think, about 7 talks that we have now. We have 2 workshops that build skills to make people better, more competent and compassionate in their communication with their colleagues. And we also have anti-stigma campaigns. And so all of these things are really have been very popular and very powerful. And in the last year and a half, we've delivered 108. I believe this is the 109th program in the we've reached at least 10,000 people, academics worldwide at this point, in 11 countries. So I'm really proud. I'm totally amazed. But this is what happens when people come together and work on something that really matters. And so I'll just touch on the fact that we have identified not only these, individual things that were programs and pieces of the puzzle, we can put that whole puzzle together into what we call our comprehensive programs. And we believe that there are now 5 domains of excellence for preventative mental health, and to help cultivate an excellent climate and culture around mental health in academia. And it involves departmental committees and peer networks, as well as all the things that I was talking about before. So please, if any of this piques your interest, join us, come reach out to us. We like I said, we have over 250 amazing volunteers from all over the world. So it's a great community to be in. So now about the talk. This talk is meant to be just a brief mental health introduction, and we'll be touching on a few of the most relevant mental health conditions, but we can't go into any of them very deeply. We're happy to discuss more specific questions about these illnesses in the discussion portion, but this is really meant to be the beginning of an ongoing conversation about mental health literacy and culture change. And so I delivered a very similar version of this talk last year. So if you were at that, we'll be going over the same things, but maybe you have more questions this time around, or this is your first time seeing this talk. So this is not meant to be a comprehensive knowledge or response training. That really would take many hours to even cover all the basics in a more in-depth fashion. And that's not everything you need to know in a nutshell. So it's just a primer. So the mental health spectrum I like to introduce, because a lot of times, talks in universities and wellness programs focus on one end of the spectrum or the other. And so mental health is really the state that we, typically would like to be in. So I think it's self-explanatory what a mentally healthy state would feel like as we go through the rest of the spectrum, because, everyone experiences stress. It's part of being alive. If you have zero stress at all, something else might be wrong. But we have, and I would imagine you're not in academia, but stress is something that there's expected and unexpected stressors that come up all the time in our lives. And so being able to move quickly from a stressed state back to a mentally healthy state is pretty typical, and not terribly difficult. Whereas the next stage in the mental health spectrum is distress. So this is a state where a little more, maybe the stressors are longer or have been going on for a longer or more serious period of time. And this is a state where someone's maybe needs more intervention, more effort in order to get back to that mentally healthy state. But it doesn't meet criteria of disease yet. So a mental illness or a mental disease is something where you can go see a clinician or a psychologist and they can diagnose you with a particular illness. And the utility of diagnoses is that we know that there are treatments for those things. And so the point of getting diagnosed is so that you can address it properly with the health professionals available to you and get back to that mentally healthy state. So I do want to emphasize that someone with a chronic mental illness, such as major depressive disorder, can, in fact, with the right treatment and support structures and behaviors, be in a mentally healthy state and have a disease at the same time. This is, in fact, the goal of engaging in treatment. And so then crisis is really that point in the spectrum that all too often in academia, we wait until we reach that point. And that's when somebody needs immediate supportive help and needs to get to care right then and there. And they often need a lot of help to get that care. So it's something that maybe someone is experiencing suicidal thoughts or has developed is in the middle of a panic attack. And so these are things that are very disruptive and very difficult to deal with for an individual themselves and often need a lot of community support and immediate support in that way. So today, like I said, we're going to be focusing on one point in this spectrum, predominantly disease, and talking about the mental illnesses themselves that are accepted in the medical community. So what makes it a disease? There's actually a pretty good way to boil it down for most of the mental illnesses, and it involves three things. One is that symptoms have to be consistent, but not necessarily constant, for more than a reasonable amount of time. So for depression and anxiety, that reasonable amount of time is 2 weeks. So if you've been having symptoms of depression for more than 2 weeks, but it can last many, many months or even years sometimes for people, that meets this first criteria here. The second criteria is that these must represent a significant change in the person's normal experience upon onset. And so this is true of the teenage or adult onset illnesses. And this isn't for developmental illnesses. We'll touch on that a little bit later as that's related to ADHD and autism. But the third piece is that the social, occupational, educational, or other important functioning must be negatively impacted by these changes. And so one of the things that is somewhat surprising to people is that if there can be people who would meet the first two criteria for, say, bipolar disorder, but their functioning isn't impaired. If that's true, both to them and to family members, friends, education, if it's objectively true, then that person wouldn't meet criteria for a diagnosis of this illness. But there's a lot of people who can deal with a lot of functional impairment, especially in academia, and they don't need to, because there's so much. There are phenomenal treatments and ways forward to improve your life and not have it be a struggle. So mental diseases, I want to make a few major points on this. And one is that they are all real, biologically and environmentally driven illnesses. They can be episodic, they could be chronic, or they can be singular events. Someone can have a single major depressive episode and never have a second one. That is possible. They're also highly preventable in most cases, and the ones that are not necessarily preventable are all highly treatable. So I'm emphasizing things today that we know a lot about. The medical community knows a lot about how to treat these things successfully and get people with a disease back to that mentally healthy state. And so critical to mental health is a climate and culture, is access to care and community support. So unlike many other physical illnesses that involve other organs, not your brain, the what we find in the epidemiological research is that mental illnesses really depend a lot on community support, which is why it's so important for everyone in the community to attend talks like this, to learn more, to learn skills, and to become adept, even if they themselves aren't going to be struggling with these things, which, by the way, no one is immune to developing mental illnesses. So it's always better to be prepared. So first, I'm going to talk about mood disorders and anxiety. So depression and bipolar disorder are mood disorders, and about 6.7% of the general population will have symptoms for this at any given time. Anxiety is a highly comorbid disorder, so it occurs at the same time with depression and bipolar disorder in a lot of cases. And about 6% of people will meet criteria for anxiety, but anxiety disorders can exist alone. One of the reasons why we really emphasize this first and foremost is both that depression and anxieties are some of the most prevalent in general, but extremely high prevalence among graduate students themselves. So in 2018, prior to the pandemic, there was a very nice article done where they showed that 39% of the graduates that they surveyed met criteria for moderately to severe depression and 41% for moderately severe anxiety. And so one of the major reasons why it's so important to know about and treat mood disorders is that they underlie 80 to 90% of suicides. And so treating the underlying mood disorder is in fact the most effective way to prevent suicides. And this is in addition to the two most immediate things to do if you or someone you know is having suicidal thoughts, is to restrict access to lethal means and to avoid substance use, which can increase impulsivity. So mood disorders, we don't have enough time to go into the extensive detail. I love to. These are my illnesses of research that I'm particularly interested in. But there's a lot of symptoms that involve more than just the mood. So it involves mood, body, and behavior, and can affect people's thoughts, what thoughts they're having, and it's called thought disorder. And so this can be extremely distressing for someone who is using their mind for their craft, their job as a postgraduate or a postdoc or a faculty member. And the causes are also fascinatingly myriad. There's many routes to reach mood disorders or anxiety. And so you can have it develop these through immune and endocrine dysfunction, through nutrition, sleep, or exercise deficiency. And as many people know, there's serotonin affecting drugs that work really well for depression, antidepressants that affect the serotonergic pathways. So we know that those are involved. And we do have many studies now that are starting to piece apart the genetics and the fact that there's a lot of impact and predisposition caused by trauma, especially early in life. And so one of the things that I like to emphasize in this talk is that having one of these disorders, one of these illnesses, does not preclude you from a very successful academic career. So Kay Redfield Jamison is a professor at Johns Hopkins, and she wrote a phenomenal memoir about herself and her struggles and experience with bipolar disorder. And so that's called An Unquiet Mind. And I'd highly recommend that to anyone interested in learning more about depression or bipolar disorder. So burnout, we like to bring up next, even though technically it is not a recognized as an illness or a disorder. It is a set of symptoms or a syndrome that is recognized by the World Health Organization. And one of the things about burnout to really clearly understand is that it's almost always very, very specifically work related. So the symptoms are emotional or physical exhaustion, reduced resilience and adaptability, cynicism about work and colleagues, reduced performance and concentration. And the causes have been discovered in the last several years to be very clearly coming from specific things work related. So chronic stress relating to work and other ongoing activities, lack of control, experiencing bullying or toxic work environments and relationships, and very, unhelpfully, this catch-all term of work-life imbalance. But the thing is that we know what helps with this as well. And the number one most important thing for burnout is taking breaks or vacation. It's also negotiating better hours, accommodations, or communications, if that's what's contributing to the burnout at work. Seeking support and building better relationships at work in an intentional manner can be quite helpful. And then mindfulness, sleep, and exercise are shown to really be activities that can help prevent and ameliorate burnout. So these things can also be helpful with things like clinical depression, but if these aren't working, and or it seems like the burnout is not work related exclusively, then it might be time to speak to a clinician or a psychologist in order to better understand whether or not this is burnout or is this depression that has other treatments that would be beneficial. So psychosis, I'm going to bring up next because it can be it's pretty rare. Only about 1% of the population will meet criteria for psychotic disorder like schizophrenia, but the symptoms are quite disturbing to the individual experiencing them, and can be distressing to the folks around them as well. And so I like to bring it up just to destigmatize and demystify this. And emphasize that it is treatable. So the symptoms include disconnection from reality, bizarre behavior, the development of delusions, hallucinations, and is often characterized by chaotic or incoherent speech and or writing, which is maybe what people will see these days as we don't interact with one another quite as much. And the causes for for schizophrenia, we know, is about 50% genetic and 50% environmental triggers. You can also cause psychosis through extreme sleep disturbances or substance use or withdrawal, specific ones. And it can also accompany other disorders like bipolar mania and borderline personality disorder. But when you see a clinician, this would be something where they would help determine what the predominant disease is. And then if there were psychotic features, that would be kind of a subtype of, say, bipolar disorder. So what helps is antipsychotics are phenomenally useful and helpful in treating psychotic symptoms. Psychodynamic therapy, dialectical behavioral therapy are both very, very good and helpful as well. And so I do want to emphasize that psychosis or a psychotic episode does not mean the end of someone's career. So Professor Ellen Sachs is someone who self-identifies as someone with schizophrenia, and she wrote a memoir called The Center Cannot Hold, and she's a professor of law in Southern California. And so I do encourage you to learn more about these things because there's a lot of stigma and judgment around it, but it's a biological disease like any other, really. And has treatments. So substance use disorder is quite common in academics circles, unfortunately. And the symptoms involve daily use, binge behavior, blackouts, lying about your use, cravings or use impacting work in some way, shape, or form, or relationships or friendships, or physical or mental health. And the causes of substance use disorder are also, unfortunately, not well known enough. And so the causes are, the estimate is about 40 to 60%, depending on the genetic studies we're looking at, to be genetic. And so this is a lot of genetic predisposition that if someone then engages in something like coping behavior or self-medication, especially for another mental illness they may actually be having, they're complicating that illness and making it worse by engaging in self-medication through substances. Social pressure and easy access can quite easily lead to dependence in the genetically predisposed individuals. And this is also linked to other mental illnesses. They're highly comorbid with other mental illnesses. And the causation there is bidirectional. So what helps though? Again, I like to emphasize substance use disorder because it is so stigmatized in society. And unfortunately, only about 10% of those who meet criteria for substance use disorder seek treatment each year. This is a stat from the US, but the international statistics aren't much better. And so we know what helps, and detoxification programs, support groups to maintain sobriety, individual or group counseling, and peer support are very, very helpful to this. And it's also very critical to treat the co-occurring mental health disorder at the same time. So obsessive compulsive disorder involves strong urges to perform certain routines or rituals. That's the compulsion. Unwanted repetitive thoughts or intrusive fears. That's the obsession. And what the impact of this is that for people who develop OCD, they may spend up to hours a day performing physical or mental rituals. And this can lead to avoidance or of triggers or people. And so the causes here are, again, we know that there's genetics playing a role. Childhood trauma also is now well known to be a major cause. And we're also seeing that potentially brain structural differences may be involved as well. And so only about 1% of the population will meet criteria for this as well. But I do include obsessive compulsive disorder because certain studies have indicated that especially in STEM fields, the prevalence of OCD may be quite a bit higher, 3.5 times higher. So that's really important to know if people with OCD end up at higher rates in the academic pursuits. So what helps? We know that cognitive behavioral therapy helps, exposure and response prevention, and certain medications. So some of the antidepressants work really, really well for OCD. Not all of them, but some of them. And I do want to emphasize that there's a professor out there, Dr. Nadine Muller, who is an academic and identifies as self-disclosed that she has OCD and talks about that on her blog. So you can check that out if you want to know more. So I'm going to end with just attention deficit hyperactivity disorder. And just to maintain time and have plenty of time for questions. So there's 3 subtypes: hyperactive, inattentive, and combined. And the symptoms, this is one of the ones where it's a developmental disorder, and the symptoms must have been present since childhood. So when someone goes in to get diagnosed as an adult, they will be going with their doctor through some of their behaviors and trying to identify whether or not there were symptoms as a child as well. And so some of these symptoms are that the person may have difficulty focusing, especially on people speaking, or if boring, easily distracted, misplacing things, experience hyperfocus and perseverance as well. trouble acting even when the intention is there, and trouble managing time. And these people can also be fidgety or restless, which is something that the hyperactivity piece captures there, and people associate with that. And what we've found is that it's about 75% heritable. So this does run in families, and but what we're finding is that, like height, for example, it's highly polygenic, meaning it involves a lot of different genes contributing to the overall risk. And then the rest is environmental factors. But what we know is that ADHD responds really well to certain medications. There are both stimulant and non-stimulant drugs that work for this illness. There's a lot of environmental supports that can be put in place, and these can be identified with a specialist in ADHD and really be supportive to a person who has this. And skills training is quite important. Psychotherapy is very helpful to support living with the condition. Psychotherapy alone doesn't necessarily reduce any of the symptoms of the illness itself, though, but it can reduce frustration and negative self-talk. And so I do want to emphasize that only about 30 to 50% of children outgrow ADHD. So depending on the study that you're looking at, you get slightly different numbers, but so there's about 6% of children that will meet criteria for this, and about 2.5% of adults. Let me see here. Just to save time, we'll go to some highlights in that mental disease is highly treatable. I want to emphasize that 80% of major depressive episodes respond to standard treatment according to the American Psychological Association. And what the literature has shown us is that awareness, early identification, and early treatment really are key. Unfortunately, the average person waits 6 to 8 years to seek treatment after the first onset of depressive symptoms. And this is really tragic because the untreated mental illnesses often gather other comorbid disorders, which can complicate recovery and delay treatment response. So really, it's like cancer. The earlier you catch it, the simpler and more effective the intervention is. But that's not to say that, it's never too late. So please, remember that and keep that in mind for yourself and others. Community support and encouragement, we've also found, are hugely, hugely impactful for seeking care and sustained treatment engagement and ultimately recovery. And so this is just something so important, and what at the core of what Dragonfly stands for and is working towards is creating community, competency, and compassion in the mental health space. And together, we are going to be able to make academia a place where mental health can be excellent, not the really poor state that it tends to be in these days. So I do want to spend just a couple minutes pointing out intersectionality of belonging to historically marginalized groups or excluded groups from academia. So people who are women, Black, Indigenous, people of color, LGBTQ identifying individuals, international scientists, people with disabilities, and first-generation scientists all experience additional stressors on top of the general stressors that everyone experiences in academia. And these, can be very simple, small things, or quite large stressors and traumas. So remarks that may seem harmless, but when repeated daily and in all aspects of life, they really do have a cumulative effect. And they serve as a constant reminder that members of marginalized groups may be less than. And this is really tragic because these are brilliant people who should be treated as colleagues and equals by the academy. And we really need to be actively inclusive in our efforts in order to, learn what we want to learn in these fields. So microaggressions can cause members of these marginalized groups to feel isolated and invalidated, and even induce symptoms such as hypervigilance. And this can lead to or exacerbate anxiety and depression. So I do want to offer solutions, because again, this is what Dragonfly is all about. We are solutions for a focused organization. And so if you happen to have noticed that you may have harmed someone, apologizing as soon as you notice that is a perfectly acceptable and important step to take. And then to be aware of and question your own assumptions. These are the ways forward if you realize that you have perhaps committed a microaggression against someone. And so the final thing I'd like to do in these talks is a comparison. The comparison I like to make is between elite athletes and academics. And the best athletes in the world train incredibly hard. They give their all to be the best in their field. But when there's an injury, even the smallest one, they respond to it immediately, even courtside, for the entire world to see, because it's so important to take care of their body, their instrument. And we are so blessed to be able to study at the highest levels in the world. But unfortunately, as scientists and researchers, when our minds, the most critical instrument for our work, becomes injured or fatigued, we tend to just keep doing what we've been doing. And I'd like to see this changed. I think that it's illogical, and we really need to work to change the culture and change the acceptability of addressing mental illnesses, mental struggle, distress at these earlier phases. So what we know now through work that we've done with Dragonfly is that stigma is the number one reason that anyone in academia has for not seeking treatment for a known or experienced suspected condition. And what we do know, fortunately, is that when they do go to seek treatment and we ask what helps, talking about it, talking to friends, talking to colleagues, getting therapy, getting that help and talking about it is so incredibly helpful. And so this is across the board, and I welcome anyone who is being held back by stigma to know that your colleagues who have sought treatment found success through talking about it. And so I'll end there. I'd love to open this up for questions for the next 15 minutes or so. And also I'll leave up this slide for a little bit. Please feel free to come join us as a volunteer or join us for a casual Dragonfly Cafe. We now are doing these only on Fridays, but they're 7 p.m. Central European time. So please feel free to sign up for that and or volunteering at the tiny URL Dragonfly Cafe Live.